our IT man behind the curtain. But before we get started tonight, we do want to take a moment to give special thanks to our sponsor for this session, American Regent Animal Health. And we'll give sponsor representative Kelly Matheny a few moments to speak. And Kelly, when you're finished then, if you would pass over that virtual microphone to Dr. Fulmer, please. Okay, Kelly, I'm not hearing you.
Oh no.
Oh, almost.
Are we back?
There we go. Okay, phew.
Let me get in closer. Here we go.
That's good. Thanks.
Thank you. Good evening, everyone. My name is Dr. Kelly Matheny. I'm a professional services veterinarian at American Regent Animal Health, the makers of Adequan and BetaVet. I want to give a big thank you to you all for attending tonight. Your passion for animals and dedication to their care is truly important and meaningful work. American Regent Animal Health is proud to be an educational partner of the AAP for over 15 years now, supporting educational opportunities that benefit the association, its members, and most importantly, the horses. We're excited to sponsor this evening's virtual event on mastering foaling and newborn management with Drs. Chelsea Fulmer and Taylor Huffman. Thank you again for taking the time out of your busy schedules to join us this evening. And if you'd like any information on American Regent or our products, you can visit aranimalhealth.com. So without further ado, I'd like to turn it over to our panelists, starting with Dr. Fulmer.
Hi guys, thank you, Kelly, and thank you for sponsoring. I'm going to just share my screen here so we can get started. We have a lot of exciting things to cover. All right, can everyone see the screen okay?
Looks good at my end.
Awesome, thank you, Karen. And don't forget to use those reactions. That helps us know you're listening. Oh, I see some hand clapping. Glad we're ready to go on. So as we begin, we're going to just start with a quick introduction to ourselves. Dr. Huffman, do you want to go first?
Sure. Hi, I'm Taylor, Dr. Huffman, and I am originally from Indiana. I am currently an associate veterinarian at the Equine Clinic at Oakencroft here in Capital District of New York State. I went to school at Ross University, did my clinical year up at Purdue, and worked at a clinic there in Indiana for a couple years before moving out here. Really, I love doing all the preventative stuff as well as repro, and I've got 5 cats, 2 dogs, and a husband who rolls with all the chaos that I throw at him. If I'm not at work, I like scuba diving, reading, and gardening. That's really, that's a baseline about me, and I'm really excited to talk to you guys tonight, so yay!
Thank you, Taylor. I'm Chelsea Fulmer. I'm actually just about to complete a large animal internal medicine residency at the University of Georgia before joining the team at the Equine Medical Center of Ocala down in Florida again. I was there for an internship previously. Before that, I was at Texas. Oh, I love the hearts. Before that, I was at Texas A&M University to do my veterinary education. But originally, I'm from Pennsylvania, so I've been kind of all over the country. I really enjoy neonatal medicine. That's the reason why I did this residency. I also like critical care and broodmare management. So this is hopefully going to touch on a lot of things that are exciting to me and hopefully exciting to you guys as well. If I'm not working, I do enjoy scuba diving as well. I love to read, I like to cook, and I really love riding my horse Apollo, who is 21 this spring, so getting up there in age. But without further ado, I just want to go ahead and we'll touch base on the AAP. I just want to make sure that we give them a shout out. Without them, we want to have these exciting opportunities to do continuing education and have so many learning opportunities. So thank you. I also want to make sure that we go over kind of the agenda so you guys have the layout for the night. So we're going to start with a quick review of how to prepare for foaling season, and then we're going to jump straight into steps as far as intervention during patrician and kind of what that looks like. We'll also go over the newborn exam. So this is going to be kind of immediately after the foal is born. What are some things we're looking at? What are some critical care techniques that we can implement to try and give them the best chance of success? And then rounding out, and I would say this is probably a majority of the presentation, is going to focus on common foal concerns. So things that you'll see out in practice, approaches to diagnosis, as well as therapies that are recommended for it. And then we'll leave a little bit of time for questions at the end. And now I'll turn it back over to Dr. Huffman.
All right, so starting off with just preparation. Getting your owners prepared and making them feel prepared is going to help you, especially if they are prepared ahead of time. Your routine care, all of your vaccines, dental care, and deworming, those are all things that we want to encourage. As far as those specifics, the AAEP actually has some recommendations in place for the vaccinations. EHV1, which is known as pneumobort, is something that's recommended. Botulism, rotavirus, and your regular routine vaccines roughly at that 30-day mark before foaling. The details about that you can find on the AAEP websites, and those are important things to remember and get in place with your owners. Same with the deworming. Everyone has a little bit of a different take on it. Some people will do immediately after foaling. Some people prefer to do a few days before and then be able to clean the stall for whatever the eggs the mare might be shedding. But really, it's a big important thing to make sure that they have vaccines on board and then maintain their nutritional plane. Mares going into foaling need to be at least at a nice body condition of 5 to 6 because you don't want them to be over conditioned because that makes it more difficult for them to give birth. But after giving birth, lactation is a heavy draw on their system. The other important thing is no fescue for a pregnant mare. That can cause a lot of different complications, including red bags, which we'll talk on later, and agalactia. So bad things that you don't want to deal with, and it's best to have them off of fescue fully, but at the minimum, they need to be off of it for at least 3 months prior to foaling if it has not been implemented before that. The other last little bit is make sure that you make sure that they do not have a Caslix in prior to foaling. And if they need a Caslix, it's placed after their cycle checks and pregnancy checks. But most importantly is make sure if that Caslix is in, it needs to be open prior to foaling so that the baby has a good place to come out.
I am going to jump right in with a question that we just got.
Yeah.
The question is, should we float the mare, float teeth during pregnancy? I was under the impression of being concerned for bacteria entering the bloodstream.
Okay, fair question. I don't, Chelsea, if you have something different to say, correct me by all means. But as far as I am concerned, I will still float mares while they are pregnant, especially if they need it. The vast majority of the time, if I am floating a mare or any horse, typically my goal is not to have any blood exposure at that point in the mouth. So obviously there's a potential there, but I would say it's more of a risk-based assessment. You want to be able to make sure that that mare can maintain her body condition score, and it is a fairly low risk.
I concur. I think the main thing is making sure that the mare is in good health. So if it's something critical that needs addressed, I think it's a good conversation to have with the owners, just to let them know. I do think overall it is a low risk, but it's not zero. And this is kind of just preparation leading into foaling. So ideally, before they're even starting about breeding, you can be having some of these conversations about how do we time that routine management to make it so it's still efficacious, but hopefully low risk.
And just also to answer a question that wasn't asked specifically about the teeth floating, but that is pertinent nonetheless, you always have to be cautious with any of the sedatives you are using. Your alpha-2 agonists can cause uterine, they don't really cause uterine contractions, but they can be a little bit more of an issue. Xylazine is more of an issue than ditomidine, but that's always something to factor in as well, just for that. But great question.
Yeah, thank you. That's all we've got right now. So
awesome. As far as getting everyone prepared on that same vein, the things that I want to know if a mare is coming to me to foal out or is in my practice area to foal out. I want to know when she was bred, if she's ever had any foals before, and if those foals had any issues, or if she had any issues during her pregnancy or foaling. If you should also test a mare's serum for anti-erythrocyte antibodies 1 to 2 weeks roughly before she's scheduled to foal, and that's to assess the risk of a foal developing neonatal isoerythrolysis, which we'll touch on later, but that's a big test that would be very helpful to minimize the chance of that happening. And then of course your important breeding information, like when was their last pregnancy check, when was their breeding date, if they don't know if they've never been preg checked, if they were twin checked, things like that. And then of course insurance, if they have insurance, and which animals are covered, mom, baby, both, how much, and that way you can determine if referral is an option or what to do if you're in a situation that needs more funds than the owner may be willing to provide or able to provide at that moment.
All right, this I want you to think of kind of as a checklist. I have it kind of divided up, so the ones on the left are things that owners could have on hand that may be helpful for them. Things on the left are things that are more specific to the veterinary side. If you notice, I have lots of lube on both because you can never have too much lube. So when preparing for foaling season, I think it's important. Again, these are kind of just a rough list, but think about how are we going to keep that mare clean? So I have on there some tail bandage, some clean towels, warm water, and soap. Before the foal nurses, you can clean off her udders and just try to make sure that the teats are nice and clean, reduce the risk of getting bacteria in. Scissors are something the owners can have. We'll talk a little bit later about a red bag delivery, but if I see that, or if my owners see that, I try to encourage them to go ahead and just open that up, even if I'm on my way out to the farm, because that's something that can be life-threatening and needs to be dealt with as soon as possible. So scissors are good for that. They're also good for plus or minus your take on umbilical clamps and ties. They can have enemas that you can administer at home. We'll talk a little bit later about the types I prefer and how often I'll do those. And then moving on to things for the veterinarians, I think it's important that you know how comfortable you are with obstetric techniques. Some people get a lot of exposure, some people don't have much. What is your owner's risk aversion? Because sometimes a phytotomy may be the only chance to save the mare, but if you've never done one of those before, there are risks of trauma to the mare as well. So this is kind of a overview of all the possible things you could have. Unfortunately, it's not a definitive list, but rather a starting point. So again, we have kind of our obstetric things at the top on the right side, and the bottom on the right side, we have things for full resuscitation that we will touch about later. And then not only is it important to have equipment, but you also want to make sure that everyone's kind of on the same page. So whether you're working in the hospital or in the field, it's important that you have your own foaling kit. So making sure that your trucks are stocked. If you work in a hospital, that your nurses' stations are all prepared. You want to sterilize any equipment that's going to be used. So I'm thinking primarily things like obstetric chains, things like that. We want to reduce the risk of contamination during that. If you do have the possibility to have oxygen, making sure that is functional is very important. There's nothing worse than if you have a little portable O2 tank and find out it's empty when you need it. So just again, kind of going through that checklist in hospital. You want to assess the available supplies. So that's going to be making sure if you maintain plasma at your practice, that those are in date, that you make sure that you have enough for your kind of expected full crop that year. It can also be things like looking for colostrum replacer, banked colostrum, looking at antibiotics that are available. Again, making sure those things are both ordered, stocked, and in date can be really helpful, because I'm sure you guys know during foaling season, things can get a little crazy. And the last thing I think is really important is just training your staff. Not only will this touch on kind of foal handling, things to look at, different vital parameters for foals versus adults, but also, especially if you're expecting dystocias, that is a very stressful time. It's very time sensitive. So I found that even as an intern back in the day, going through that kind of practice run, made sure that I was fresh on everything and that everybody knows what roles are expected of them. So I think while you're gathering all your equipment, making sure that you're touching base and getting your team on the same page is equally as important, if not more important.
Chelsea, I'm gonna pop in real quick because I saw a question in the Q&A about why is Detomidine safer in pregnant mares than xylazine. I am not an organic chemist or a chemist in any capacity. It's just been demonstrated that it has less impact on uterine contractility than the xylazine. So I can't tell you the ins and outs of it, just that has been shown to be the case.
Awesome. Okay, signs of patrician. These are things that I'm sure you guys have been seeing, but just to kind of make sure we're all on the same page. So you're looking for things like udder development, waxing up or dripping of the milk. You also see loosening of perineum, and those are things that I really talk to my owners about, making sure they're kind of keeping eyes on. However, the one that's kind of, I think, more interesting, especially in a hospital setting when we're trying to be really specific about these mares, we can also monitor for those changes in milk composition. So we can make sure that we're monitoring our milk pH. Kind of that magic number is when we see it decrease to 6.4 or lower. It's normally a good indicator that patrician is going to be imminent within the next kind of 24 to 48 hours. And then you can also look at calcium concentrations. Another one you can look at is sodium, but I kind of look at calcium and sodium, those electrolytes together, just to try and give an idea. Unfortunately, there is no perfect method for this. Everything is an estimate, and my mares never like to read the books, but hopefully this can give you guys a little bit more peace of mind when you go to bed at night, that hopefully the mare won't foal out that night. We'll also do just a quick overview at the stages of patrician. Again, I'm sure you guys are familiar with this, but stage 1 is kind of that preparatory stage. So this usually lasts 30 minutes to 4 hours. The foal is hopefully getting into the correct position, and the uterine contractions are starting to really engage that foal, kind of going into the birth canal. Stage 2, that's the exciting one. This is the active labor stage. At this point, the mare's contractions are very powerful. They're often laying down. You'll see that good abdominal press. The chorioallantoic membrane should rupture. So that's kind of the water break that we tell owners to look for. As you know, the mare can move around a lot. It's normal for her to rise and lay down during this time, even if we're seeing the foal's legs already. It's a very normal behavior. Ideally, in a normal presentation, the foal's forelegs are extended. You'll have one hoof slightly in front of the other, and then the nose should be following shortly after that. As the feet become visible through the amnion, so that's kind of like our picture we have here, the mare is normally kind of pushing the foal's shoulders through the cervix. It's normal for her to take kind of a little bit of a brief rest during this time before pushing out the rest of the foal. But I do like to tell owners, or if you're there for the foaling, to time these. I think it's really important that while we're engaged and kind of monitoring, we don't lose track of the duration of them, because as I'll kind of talk about later, making sure that you are actively intervening when necessary can really be life-saving in these cases. And then the last one that we'll touch on is just about the expulsion of the placenta. As we talk about when to intervene, one of the big scary things is going to be a red bag delivery. So this is a delivery complication. Luckily, that's not very common. However, when you have normal patrician, the chorioallantois, which is kind of that outer layer of the equine placenta, should rupture at the cervical star and release a large amount of allantoic fluid. At that time, the amnion, and that's that thin white membrane that was in the other picture, is the only covering over the foal. However, when you have these red bag deliveries, the chorioallantois may be visible and intact. That's kind of that red velvety appearance. During this time, the important thing to remember is oxygen delivery to the foal is compromised. So this is one of those times I tell the owners, if you have a scissor or something sharp that you can use to carefully open up that bag and try to open up the airway for that foal, that's going to be really important. If this is happening in hospital and you're actually able to intubate the foal, this would be a case where that may be warranted. It's also recommended that these foals are delivered as soon as possible, and generally afterwards, if you have the feasibility to do oxygen supplementation, this is a case I would reach for that, as they're at a high risk of hypoxic injury and then that secondary neonatal maladjustment syndrome, which we'll talk about more later.
All right, and then back to our last stage of labor, which is the expulsion of the placenta. So this usually occurs within 15 minutes to a few hours after the delivery of the foal. If the mare is up and moving around, you want to tie the placenta up if it's not yet passed. You can wrap it around itself. You can use baling twine, all of those things, just to get it up to keep her from stepping on it and putting pressure on it, just allowing gravity to do the work for you. And at that point, just allow it to be there unless it has been more than 3 hours, and then we might need to intervene. When the placenta is passed, it should look like an F when it's all laid out, and you want to be sure to examine that fully, as any missing part of that placenta could be indicative of a retained fetal membranes and can cause some major issues with the mare, including severe infection, laminitis, and infertility. If there's a long delay in passing that placenta, greater than 3 hours, that's when you're going to get the call from the owner that says that she hasn't passed her placenta yet. If you've got excessive bleeding or severe abdominal discomfort, that is a big red flag. Uterine artery rupture is a thing. That is a very scary thing and is a terminal thing typically, especially in a field setting. If she has not passed that placenta, you'll need to treat her. And for retained placenta, there's a few different ways that you can do that. First, make sure that it is tied up, and you can start with oxytocin. IV, usually about 5 to 20 units every 30 minutes to 2 hours. Additionally, after starting with the oxytocin, you can start with some of these other methods, one being just gentle traction, and I mean very gentle traction. This is not pulling, this is simply your arm in the uterus, holding, well, in the vagina, in the uterus, holding onto the placenta, and it's meant to allow that tissue to release, not to pull it out. It's just allowing that to release on its own. There's also something called the Burns technique, and that is the way you do that is you distend the chorioallantois with saline for about 15 to 30 minutes and distend it. So that way, then whenever you drain it, it also hopefully either releases while it's full or releases when you drain it. You can also catheterize an exposed umbilical vessel to distend the fetal membrane vasculature as well, again, in order to allow that to detach on its own. And again, once that is out, you always want to examine it for completeness, because if you have a small piece of retained placenta, that can still cause a big problem. And if you're ever concerned about retained placentas, you want to thoroughly lavage that uterus and start on broad spectrum antibiotics, monitor their temperature, and monitor feet and digital pulses.
All right, an exciting topic. So I guess a little asterisk, I am not a therioanginologist. I have wonderful theory service at UGA that I get to rely on, but I've been able to pick up a few things, and hopefully this will be able to help you guys a little bit too. So the term dystocia refers to a difficult birth. It has a reported incidence of about 1 to 4%, depending on the population of mares that you're working on, but it can occur for a variety of reasons. So the main one that we tend to see is issues with presentation, position, or posture. So generally during the first stage, again, if we're lucky, if we're one of the 99 to 96% of people, the foal should position itself into an anterior, that means head first position, with a dorsosacral position, as shown in the diagram on the screen. If the foal is not in that kind of typical position, it can make things much harder for it to kind of be delivered. When we refer to presentation, that is a relationship of the long axis of the fetus to the dam's birth canal. So here it's an anterior presentation, meaning head first. If its rear end was coming at you, kind of more what we think of like a breech position, that would be a posterior presentation. When we discuss position, that is the relationship of the dorsum, so the top of the fetus, to the quadrants of the maternal pelvis. So in this case, when we're talking about it, we're looking at a dorsosacral position. You can also have them in a lateral position where they're going sideways, or where they're actually flipped upside down. And then the last one is posture. And I would say this is a pretty common one. And this is the relationship of the fetal extremities to the fetus itself. So if you have a forelimb that's not extended all the way, a head that's turned to the side, something like that would be termed posture. There are a variety of these kind of malpositions that can appear. We talked about the posterior presentation. You can have incomplete limb extension, there's head flexion, and there's also ventral or dorsopubic positioning. Malformations is something else. This is definitely less common, but some examples of malformation that can result in dystocia would be things like congenital abnormalities, or sometimes I've seen where they have markedly contracted tendons that can cause some difficulties because you can't get them to kind of proceed through the birth canal appropriately, or they can just cause a lot of damage on the way out to the mare. The last one would be an increased fetal size. Some people also term this a fetal maternal size mismatch. This is less common in horses. It's been reported in cattle and some other species. And I would say dogs, you can see this a lot too. Think of like the Frenchies or things that require C-sections. It can happen though if a small mare is bred to a stallion that's too large. The other instance when I can think of this would be following like a fescue toxicity, when you have that prolonged gestation. So now that we've talked a little bit about our dystocias and what cause them, what can we do about them? And I'm going to give a shout out. Dr. Xavier, I think, is actually on this talk, and that's her in the picture, saving another life. So thank you, Dr. Xavier, for being here tonight. So to start with your dystocia, I think the first thing is remember the mare is a patient. So a quick evaluation of her, making sure that she seems systemically stable before sedating and proceeding to work on the foal, I think is very important. Generally, you want to kind of clean up her vulva, wrap the tail, trying to just keep things as clean as possible. So you can see in the picture that that's been done. And then you'll go in with a gloved hand and make sure that you palpate the foal. It's really important to determine its positioning, because some malpositions can be corrected on the farm, while others should prompt immediate referral if that's an option. So for example, if a foal presents with, let's say, like incomplete elbow extension, or maybe even just where it has flexion of the carpi, that's something that you may be able to retract the foal into the uterus and then be able to put gentle traction and correct that. However, for a foal that's in posterior presentation and has like hock or let's say like hip flexion, that can cause a lot of damage to the mare, a lot of trauma. So in that case, cesarean section is generally preferred method of delivery. And we understand that's not always an option, right? So we want to make sure that we're using good technique and just making sure the owners know what options are available. But moving forward, the first step to fixing this would be manual manipulation. So this is what we kind of term assisted delivery. This is in a sedated mare. Oftentimes that mare can have an epidural placed, but they should remain standing for this portion. You're able to use OB chains or OB straps to go in and try to provide traction on this foal. And the goal is to correct the positioning to allow for that foal to be delivered vaginally. Some of the tools that we discussed previously, like I mentioned, the OB chains and head snares can be really helpful at this stage. But my biggest recommendation here, and if you noticed, it was listed on your equipment list twice, OB lube. Oftentimes we'll have people pumping lube in as someone's trying to manipulate it, trying to actually distend that uterus a little bit or kind of that birth canal as much as possible, and keeping it lubricated to facilitate movement of the foal is going to be hugely helpful. So once again, lots of lube. If you're unsuccessful at this stage, the next step is going to be doing a controlled vaginal delivery. This I generally recommend only doing in a hospital setting because we do want to anesthetize the mare. And oftentimes we'll try to elevate their hind end to facilitate more easily, a more easy time trying to reposition the foal. You're able to get a little bit more momentum behind it. When this happens, again, this is a really important time that you're keeping track of the amount of time you're spending on this, because if a mare has a cesarean section, you don't want to spend too long kind of doing the manual manipulation when you could be actually putting that foal at risk. So generally speaking, if you have the option to go to a C-section and you haven't resolved it otherwise, within kind of 30 minutes to an hour max, you want to be moving on to doing a more advanced procedure like a C-section. And that is from the start of stage 2 labor, not from the time you see it, not from the time that it comes to the hospital, but as soon as that owner says, you know, the water broke, we want to be making sure we're timing. And the last thing is a tough one to see, but an important option to give owners if that foal is deceased. If there is no other option to remove it, we failed at manual manipulation. You can perform a phytotomy. I do say it's important to warn owners that the intervention is necessary. We can't leave that foal behind and expect the mare to go on with her life. However, there is a risk to the mare. Also, when we're doing a phytotomy, just causing trauma to that uterus. So I think it's important that you're just very upfront about that this is her best chance, but there are risks associated.
All right, and I'm gonna address some of the questions that I'm seeing in the Q&A. And Chelsea, if you want to pop over and look at some of them too. There were a couple on, I had one about what solution do you use to flush mares for retained placenta, a sterile saline versus a homemade isotonic. I have used both, and as long as you are able to keep things as clean as possible, you are flushing in. I still use, I think the homemade isotonic was distilled water with pickling salts. And that versus LRS or saline, I have used both of them and they both have worked very well for me. As far as someone asked why should we wait until the placenta is considered retained to treat? I'm not necessarily saying you have to wait. You can also intervene with oxytocin prior to that 3-hour mark if truly needed. But most mares will typically pass that on their own. And a lot of times the owner is not necessarily calling you at that first bit if everything else went normally. So it's one of those things that the 3-hour mark tends to be the cutoff because we have to have a cutoff somewhere. So, okay.
Yeah, I can jump in on one of these. So one of the questions was asking about the Ceramune. So for those of you guys who may not be familiar, that is a oral IgG supplement that's given. I actually think that the question makes a little bit more sense on if you don't have colostrum. I think it's fair to reach for that. To be honest, I'm not as familiar with that product or the literature behind it, but if it's an oral supplementation, you'd want to make sure that you're using that when the gut's still open. So within that kind of 12 to 24-hour marks. If you don't have plasma, I don't think it would be wrong to supplement with Ceramune, but I think, again, if you're not within that time frame, the colostrum is going to be the most important thing. So Ceramune after that 24-hour mark is probably not going to be very effective. And those would be foals that I may prophylactically start on antimicrobials or just very closely monitor for signs of sepsis because they're not going to have that innate immunity that's so important.
All right.
Do you want this one? Go ahead.
Go ahead. Go forth.
Okay. So there's a lot of questions about how do you know if the foal is deceased? And that can be a tough one. So sometimes they make it easy for us. You know, if the mare shipped in from like 4 hours away, you can actually start to feel like crepitus and things in the foal. That is a pretty significant sign that they have passed. Other things you can do is you can try to actually put a little pressure on their eyeball and see if you can get a response that way. You can look for movement. If you have an ultrasound, one of the best things to do is to look for fetal heart rate. And that's one of the things I see Dr. Jacobson has a question about assessing fetal viability in utero. We really rely heavily on using our ultrasound to look at heart rate. Not only can that tell me, is it appropriate, but it can also tell me, is the foal still alive? So kind of step 1, are you alive? Step 2, are there signs of distress? Is that heart rate really low or really increased for that? The other benefit we have with ultrasound is if you go in transrectally, you can look for signs of like placentitis or other things that would put your foal at risk when you kind of measure that placental thickening. So I think ultrasound is my go-to thing for that, but if they're actively in labor, going in and manually kind of palpating the foal and looking for reactions is another thing you can do.
All right, and then I'm gonna scooch on to the 1, 2, 3s of neonates, which I think we all basically know. Hour 1, your foal stands. Hour 2, the foal nurses, and hour 3, the meconium passes, and the mare should have passed the placenta. If the mare or foal does not pass one of these milestones, that is when you're going to get a call and you're going to need to get involved. So always be ready to roll if you've got a mare that's close to foaling or in your area, because foals are time sensitive. So don't wait, don't delay type of deal. And there's a saying that plenty of people have that I love, that is applicable to anything that involves the mares and foals, and that's prior proper planning prevents poor performance. Knowing what you're going to need to do and when you're going to need to intervene, especially, and your owners knowing that type of information too, is going to make everything a lot easier on you.
All right, moving on to our newborn exam. So this can be a little controversial as far as when do you want to actually assess the foal when it's been born. A lot of people like to leave the mare and foal kind of do their own thing. I tend to be a little bit more aggressive. And what I mean by that is I don't like to wait on these foals, because if something's going wrong, the faster you intervene, the better the outcome. So for me, once the foal is born, if I'm present, I like to evaluate it before it stands and while both the mare and the foal are kind of resting. So this picture here is a great one of saying they're both out, they're both just kind of relaxed at the moment. And this would be a good time to kind of go in and see how they're doing. And the reason why I do it then is I kind of do my checklist that I have listed there. If those things are looking good, if I have no significant concerns, then I can step back and I can give the mare and foal time to bond. I don't have to intervene again. I can really just do kind of a visual observation. When I start the exam, I just want to emphasize that this is just a preliminary exam. This is looking for immediate signs of distress, things that the foal would need kind of addressed. It does not replace the neonatal exam. That's kind of the exam we do somewhere between 12 to 24 hours that we'll touch on later. So again, this is once that foal hits the ground, what are some immediate things I'm looking for? And to start, I always want to clear the airways. You know, we talked about how important oxygenation is to these guys, especially in a red bag delivery, making sure their noses are clear. So removing that amnion. The other thing, which I recommend some caution with, is I do like gentle suction of the airways, but it's not something that I would do repeatedly. Really just to kind of help them clear, and then making sure they're in kind of that sternal position is my kind of first steps as far as the airway goes. Then I like to listen to heart and lungs. I want to emphasize it is normal to have a murmur at this time. These murmurs can be caused from a variety of things. I would say the most common is kind of a continuous machinery murmur, and that's because that patent ductus arteriosus. This should go away within the first few days of life, but sometimes they can have systolic murmurs, whether that's because their foramen ovale is still patent or just because they have their great vessels there and we're hearing that kind of physiologic murmur. When we're listening to them at about a minute of age, the foal should have a heart rate of about 60, and it can definitely go up from there. I actually have a sheet on the next page that'll give you kind of expectations for where those heart rates should be. But by 1 to 2 hours after birth, that heart rate should increase to about 80 to 120. I just kind of in my head think it should be around 100. And that respiratory rate should actually slow down and should be closer to 30 to 40 breaths per minute. Some landmarks I like to use: by about 10 minutes of age, a normal healthy foal should have a suckle. So as I'm doing my exam, that's definitely something that I can feel for. When I encourage people to do this, if you're putting your foal or putting your fingers in the foal's mouth, it's very important to have gloves on or make sure your hands are very clean, because again, we don't want to be introducing any bacteria or any contaminants into their GI tract while their gut is open. And what we mean by that is while they have kind of a better ability to absorb those good things as far as IgG and bad things as far as bacteria and other contaminants. I'll also palpate the umbilicus. I just want to make sure that we don't have evidence of ongoing bleeding there or kind of seeing how much is remaining. If you like to use a clamp or a tie, this is the time I put that on. I do think this is pretty, it's up to clinician preference. Some people like to make sure the placenta has time to drain into it. I don't think there's enough in the literature to really dictate which way to go with this, but that's one thing if you guys want to include into the chat what you do. I'm happy to hear about your experiences with it. If you do use a clamp or a tie, I generally don't like to leave those on for more than about 24 hours, and I still implicate some disinfectant care for them. Well, I'm looking at the umbilicus. I'm kind of looking towards the hind end. I do like to find out the sex of the foal, just so that we kind of have that on record and know going forward. The other thing I'm looking for while I'm looking kind of at the whole body is any evidence of meconium staining, as that would tell me that that fetus probably experienced some fetal distress, and that as a foal, we want to be making sure we're looking for signs of aspiration or looking for signs of sepsis. And then one of the last things I do is I palpate the ribs for fractures. This can really impact their ability to breathe and ventilate appropriately. So knowing kind of what we're dealing with there, looking for things like a flail chest, where you have multiple rib fractures that are impacting the ability of the thoracic cavity to work appropriately. And then the last thing is I'm looking for any major limb abnormalities. And the real reason why I'm doing that kind of just on a brief exam is because those can actually hinder the foal from standing and nursing. So if this is one where they're going to probably need assistance to stand and assistance to nurse, I just want to be made aware of that. So again, I can intervene as soon as possible. As promised, here is kind of this guide. This is from Dr. Magdesian on the Equine Emergencies page. I just found this really helpful. It's something I share with students. It's kind of a gauge of what to be looking for as normal. Obviously, this is a range, but I do think it's kind of a good starting point of looking, where should I be? So if you just remember 60 for heartbeat and respiratory rate and kind of those young ones. Oh yeah, lots of hearts. Dr. Magdesian is incredible. This can hopefully help you guys just know what to expect depending on when you're seeing them, because once again, the foal can really change a lot in those first 24 hours, really the first week, and knowing what to expect helps you do a more effective physical exam. You guys are probably tired of hearing from me. We're almost done with my section here, but I just wanted to quickly touch on what to do if the foal is delivered and is not responding appropriately. So we'll first touch on kind of our CPR, focusing more on the cardio component, and then we'll talk a little bit about respiratory support. So if the foal is delivered and does not have a pulse, we recommend starting chest compressions right away. Normally they go about 100 per minute. It's easy. They have little metronome apps that you can find now. There's also a ton of music out there that I'm sure you can find to bop along to. The other thing that we recommend trying to do as soon as possible is secure the airway. Supplementation with oxygen is also recommended during these cases. The next step would then be to try and secure venous access, and this just helps with drug administration. So if you have emergency drugs, a lot of them can be given in multiple routes, but if you can give them IV, it's generally the preferred method. And then the last thing that's really recommended is looking at what other monitoring we can do, because we want to make sure that we're being effective in our CPR. So placing an ECG can let us know if there is any progression as far as electro activity within the heart. I will say, if you're actively doing chest compressions, your ECG is pretty close to useless, but when you're pausing to reassess your patient, that's a really good time that you can be looking at that ECG. And then the next thing is, if you do have them intubated, using a capnograph really lets you know if you're being effective in your ventilation that you're providing. Moving on. This is a nice sheet that I had found. It's in Neonatal Foal Resuscitation Veterinary Clinics 2007. Some things I just wanted to kind of point out about it. There have been some changes. If you guys are reaction time, how many of you guys know about the Recover guidelines that are available for veterinary medicine? Yeah, some thumbs up. Those things are great. I live by those things. It's really frustrating though, because most of it is for small animal patients. So hopefully here in the coming years, we can do things that are more tailored to our large animal patients, because as you guys know, they have their own host of complications and challenges when we're dealing with them. But I have highlighted here in red 2 of the drugs that we use most commonly during the CPR. It's important to note that there are 2 doses of epinephrine. Currently, the recommendation by Recover, and those are the new 2024 guidelines, is to do a low dose rather than the high dose, as that high dose that's listed has actually led to decreased survival at discharge and can cause some issues kind of with the myocardium. Those same guidelines, so again, the recovery guidelines, also mention a slightly higher dose of vasopressin, and that's the 0.8 units per kg, and that's a one-time dose. So I just want to emphasize that epinephrine you can do every kind of 3 to 5 minutes, depending on response. But when it comes down to the vasopressin, it's really just recommended to do once. And then moving on to our respiratory support. So this, I would say, is one of the most common things that newborns require. And part of that reason is because hypoxemia is one of the most common reasons for bradycardia. So if you have a decreasing respiratory rate, a decreasing heart rate, I think it's really, really important that we try to prevent that hypoxemic injury and focus on restoring our airway. So securing that airway, that's the first step. Ideally, we recommend orotracheal intubation. If that's not possible, a face mask can be used, although this can be less helpful for assisting with ventilation unless you have one of those masks that are really well fitted and actually allows kind of a one-way air valve. Additionally, and this is something that I have not got to try yet, but I have read about and I've heard that is very successful, because foals are obligate nasal breathers, as all of our equids are, you can actually do mouth to nose ventilation. I would recommend kind of cleaning up the foal a little bit very quickly, giving it a wipe down, making sure that you're staying safe as well. But what you can try to do is actually manipulate their head in certain positions to try to decrease any aerophagia, so trying to decrease the amount of air going into the esophagus. You can also try to put your fingers over the esophagus and prevent air from going in that way. And your goal, regardless of what way you're ventilating them, is to aim for about 6 to 10 breaths per minute. You can also try to use some tactile stimulation. So in order to get them to breathe, you'll see a lot of times people are vigorously rubbing them with towels. You can tickle inside their ears or in their nostrils, anything to kind of try and irritate them, for lack of a better word, annoy them maybe. And that stimulation can be enough to kind of trigger respirations. Other people, although not shown in horses, in other species have looked at acupuncture points, and it's kind of right in the nasal planum. So I have tried that point. Again, horses don't have a nasal planum, so I just kind of go right in between their nostrils. And that's just something else when you're reaching for everything you can do that probably is not going to do any harm. And then the last thing is medication administration. And this one can be a little bit challenging. So you can give caffeine. Generally, this is oral though. So if you have a patient that is not breathing well, that can be a difficult ask of them. They may not be swallowing at this point or may not be mentally appropriate for that. But the good news with caffeine is there's very little negative side effects, even if its efficacy is questionable. The other medication that can be administered is Dopram or Doxapram. However, this is generally not recommended for acute pulmonary resuscitation foals because it can actually reduce cerebral blood flow and increase myocardial oxygen demands. I do think this is a little bit challenging because the literature shows that it is effective in decreasing the PaCO2 concentration. So if you have a foal that just will not breathe on its own, if ventilation is not an option for it, or the new fancy high flow oxygen therapy that some hospitals have, I think you can kind of warn the owners, like, this could cause long-term damage, but if it doesn't breathe, it can't live. So that may be a time when Dopram, although not recommended, is the only option you have. And again, I reach for this kind of respiratory support if they're not spontaneously breathing, if their respiratory rate's low, if they're bradycardic, or if you're able to do a blood gas, if I see that we're starting to creep up with that.
All right, so full restraint. This is going to be important for anything that you have to do with that baby. Once they enter the world, they need to be able to be safely handled. It's going to help you help them. In general, less is more when it comes to the babies. They're very, very sensitive to stimuli, and so being very conscientious of your actions and what you're doing to potentially stimulate that foal is going to be helping you out in the long run. It's recommended typically to only grab those firm or bony areas. You don't want to grab the ribs or the abdomen or the legs if you can avoid it, because especially you may have rib fractures, you can cause damage to the abdomen, and you could, depending on the size of the foal, you could accidentally cause rib fractures, especially if they are fragile. There's a method called the Madigan foal squeeze. This is a great method for foal restraint. It mimics going through the birth canal, and most foals tolerate it really well. You can use that for procedures that might need to be done, such as ultrasounding if you need to do that, or to administer fluids without stressing the foal out or having to follow a foal around a stall, going a million miles a minute whenever it decides to jump up.
So this is just kind of an overview of the newborn exam. So when you're first going out to see it, if you weren't there for when it was actively born, this is the one that's going to be a little more in depth. Oftentimes insurance claims will require this to be performed, but it's where you really get to kind of discover if there's ongoing issues. At this time, I would check my IgG levels because this is really when intervention is going to be most effective for them. It's the time, if you haven't already evaluated the placenta, to also examine that. I do a full physical exam, and we're going to take you through in this next section, kind of step-by-step systemically, what are some things to monitor for. And then based on my findings with that, you can also do additional blood work. So complete cell count and a chemistry are very helpful, especially if this is a foal that you think could be at risk for sepsis. Hint, most foals are at risk of sepsis. So making sure that we have kind of all that information can be really useful for doing some of the sepsis scores that are out there in the literature. So we talked a little bit about colostrum, but this refers to the first milk. Good quality colostrum should be thick and golden in color. We had some questions about how to evaluate that. So a Brooks refractometer can be very helpful. Generally, you want it to read as higher than 23%. That's kind of one of our cutoffs we use. The IgG concentration can also be measured by a single radial immunodiffusion. And that's kind of the gold standard. That's the one you see in a lot of the literature looking at that. And the goal for that is to have an IgG concentration greater than 80 mg per mil. To help produce that nice high quality colostrum, it's really important to follow those vaccine guidelines we alluded to earlier, and also the vaccine label instructions. And if the foal does not get adequate colostrum intake, or maybe that colostrum just wasn't absorbed appropriately, or maybe it wasn't high quality colostrum, supplementation with colostrum is really important, or plasma transfusion. Side note, I actually had one of these cases this spring. Do not use bovine plasma for plasma transfusions. This can cause a life-threatening anaphylactic reaction, and it actually made it so that we couldn't give any other plasma to the foal, and it just had to be covered with antibiotics. So that's kind of my public service announcement. In a pinch, it is better just to prophylactically cover them with antimicrobials rather than risk a life-threatening anaphylactic reaction. And as we touched on, while the colostrum is really important, it also has to be absorbed and utilized by the body. So there are a few ways we can do this. This was a question that an audience member had, so I'm going to try to quickly go through it, but make sure we're addressing that. So you can use a measure of total protein or total globulins. There's a study that looks into that, and it is helpful to estimate failure of passive transfer, but they are generally thought to be less sensitive than other tests. On this page, we have a picture of the stall side snap test that IDEX does. This is a really handy way. It's helpful because it only takes a few minutes to run. It can be performed stall side, and it's easy to read the results. I will put another asterisk on this. I have a colleague who's colorblind, and it is less easy for him to read those results. So if you are colorblind, that may be a difficulty that I was not aware of before. So one negative to this. I would say some other negatives for it is that it can be, it has to be stored refrigerated, and it does not give an exact IgG concentration. But the fact that it is so quick, it can be used on fresh or refrigerated blood. It can also be used on blood, serum, or plasma, are all things that make this a very convenient option. Another common one in equine practice is the VMRD lateral flow assay. This is something that is marketed also for SAA and a few other measurements that it can perform within the horse. I would say this one is really helpful because it is actually a quantitative IgG concentration, so it gives kind of an exact number. It does not require refrigeration, but I have it on good authority that it does prefer to be kept in a room temperature environment and plugged in for kind of best effects. There's a variety of other tests. So we can do the single radial immunodeficiency, just like we do for the colostrum. This is kind of the gold standard, but it requires specialized equipment. There's a variety of other tests that can be performed. Most of these are done in a laboratory setting, and their sensitivity and specificity kind of vary depending on the test that's used. I would say the final test that I have kind of seen done on farms is the turbidometric assay. It's been a long day, folks. This test actually used a goat-derived antibody, and this forms immune complexes with the foal's IgG. The benefits of this is the assay is really rapid, it's simple to perform, and it uses a calibrated machine that may be present on many breeding farms and veterinary clinics. So this is another option that I've seen used clinically that has good results.
All right, and I'm gonna pop back over to the Q&A really quickly. Someone asked, up to what age do foals generally respond to the foal squeeze? I was told at one point it was like 3 days. I know I have used it, and it becomes less efficacious after that. I have used it on a week-old foal, and that did work really well for me, but I think it's just going to depend on the foal. But from what I've been told or was told in the past, it was like that 3-day mark is really the typical response, and anything after that, you may not get the effect you want. And as far as someone also asked about tail jacking or holding the tail up for full restraint, and it's commonly done, but they'd heard it can cause damage to the spinal cord. And I would say it absolutely, if it's done excessively or incorrectly, it could absolutely cause damage to the spinal cord. You could see things like cauda equina syndrome. And in general, you want to be very careful because just like if you were trying to get another horse up, like really yanking on their tail, like you could in theory pull a tail out of a horse if you apply enough pressure. So when it comes to the tail jack, you just want to be very careful if you do try to implement that. I know some foals do enjoy a little playing with their tail, but you just want to be very careful that you are not applying excessive pressure and you're doing the tail jack correctly if you are going to implement that method.
I can kind of jump in here for the bovine colostrum. So I prefer, there are some mixed species ones out there. I do find they're a little bit less efficacious. And what I mean by that is most of those are derived from bovine colostrum. So again, it's not giving the specific equine IgG that we're wanting, but in a pinch, if that's all you have, I think it is better for them than nothing. And I would say I have not appreciated an anaphylactic response to that. Again, because it's getting absorbed. I would say if anything, it's just not, it doesn't stay around as long in the body. But again, if you guys have other experiences with that, I'm happy to talk about that one. The last one is asking about our NI foals, and we'll talk about those shortly. And then I know we had a question about what we could do for a dystocia. Since that's a specific example, let's save that to the end. If we have time, we'll chat about it. But I didn't want you to think we were ignoring you.
All right, so a reminder, I know we all know that the mare is a patient, but it bears repeating. We can get really zeroed in on that baby and forget that that mare is also your patient. At the time you do the full exam, you should also be thoroughly examining the mare. Do a full body exam, and the areas that you're going to want to pay special attention to are her vulva. You're going to be wanting to look for tearing or bruising, and especially any sort of rectovaginal tear, because that is something that will need to be remedied. Mild tearing and bruising you can manage very easily, and typically they will heal very well from, but you want to make sure you know the severity that they are dealing with. You want to make sure you look at the teats and the udder. Make sure, one, that's also going to give you information about if your foal is drinking or not. You want a supple udder that has been milked down. You don't want her tight and streaming milk. That could be an indication that baby is not nursing. And the other thing to remember is her GI system. We all know horses are going to colic with the weather change or looking at them incorrectly. This mare just had a giant full uterus and has cleared that out, and now everything that has been pushed out of the way previously for those 11 months is making its way back into its normal position. So you always want to make sure that you know if that mare is pooping, if she has an appetite, and if she's having any sort of colicky signs, because that could be an indication that either something is wrong in the GI tract or potentially even something is wrong in the reproductive tract.
All right, now we're getting into those common foal concerns.
Oh yes, that's still me. I'm sorry. So the common foal concerns, yes, starting off with one of the rough ones, the premature, dismature, and post-mature. So these guys are all similar versions of the same thing. Premature is if they were born before their term. They're often small with a lot of joint laxity. Most of them are going to require extra support. Same with all of these. A dismature is born at term, but it presents like your premature foals. Same generalized muscle weakness, joint and tendon laxity, might have a domed head or some floppy ears. And then your post-mature is after term. They usually have normal skeletal development, but they're thin to emaciated, and the longer that baby cooks, the weirder it gets. So all three of these are seen with your high-risk pregnancies more commonly than anything else. And all three of these should have oxygen supplementation and probably will need positional support for that optimal oxygenation and ventilation. And like I said, they will almost always have some musculoskeletal abnormalities that you're going to have to deal with. So most of the time, these guys are going to need a referral to a hospital setting that has the staffing and the around-the-clock care to be able to support them, because it is a very intense job supporting these guys. And if referral is not an option for an owner, depending on the severity of how affected they are, if you have a hospital setting and the ability to support them, you can try, but it's always something to remember that euthanasia is an option for cases that cannot be humanely managed. It's a sad but very pertinent truth.
Definitely. I would say that's kind of a theme for all of these, is we want to give them the very best shot, but sometimes either financial constraints or resource constraints make it so the most humane thing to do is let them humanely pass on. But we're focusing on the things we can do to try and fix them. So this is another syndrome that has it's one of my favorites, but can be really intensive in its management. So neonatal maladjustment syndrome, aka dummy foal. There is a plethora of names that people have called this, but essentially these are the foals that come out and they just ain't right. They may initially appear normal, and I would say that only about 1 to 2% of foals are affected. So it's not super common, but generally these are foals that maybe are a little slow to nurse, or maybe they initially nurse really well, but then by 24 hours are just not normal. They can appear confused. They may have difficulty nursing. They can be lethargic. And then when they start getting more severe, kind of like our poor little creature there on my picture, you can see some difficulty regulating body temperature. They may be hypoglycemic. You may even see things like difficulty ventilating. So that brings us to kind of our laboratory findings. These ones are often hypoxemic, hypercapnia, again, not ventilating, not able to oxygenate the body appropriately. That results in them being acidotic, hyperlactotemic, azotemic, if we're not getting blood flow appropriately to those kidneys or able to oxygenate them. They're not nursing well, so they can be hypoglycemic. They can have multiple electrolyte abnormalities. There's one interesting report that they can also have low thyroid hormone concentrations, although to be honest, that is not something that I routinely check in these guys. The interesting thing is, in a hospital setting, that about 80% of them are reported to survive in a referral hospital, and most of them do not have any long-term deficits. But what are some treatments? What are some things we can do to try and help these guys? So one of them was already touched on by Dr. Huffman. That is our mannequin squeeze technique. Really cool. I like to use this. Again, it kind of keeps them calm if they're maybe just a little bit dummy, or even in the foals that are very normal. This is a good way to practice restraint, but the goal is it kind of replicates that birthing process and tries to do kind of a hard reset. I like to joke with my students, this is the equivalent of saying, have you turned it on or turned it off and turned it back on again? Another thing that is used commonly throughout the industry is dummy jugs. And if you talk to someone, everyone has their own recipe. It's their special cocktail or concoction. Some things that are used in it, I've seen mannitol, naloxone, DMSO, dexamethasone, banamine, dextrose. Personally, I tend to use DMSO, vitamin C, and either vitamin B complex or thiamine, depending on what the hospital has. But the unfortunate thing is there's just not a ton of research available for them. Some people like to use magnesium sulfate's another one that I've seen kind of some emerging research on. So the goal is do no harm, maybe do some good. Supportive care I find to be really important on these guys. So again, if referral is an option, that can often be the correct solution, because they can need really intensive nutritional support. We're talking like dextrose or maybe even TPN. Sometimes we'll have to place a urinary catheter so we can monitor urine output, especially if we're starting to see this foal's azotemic. Maybe we have some acute kidney injury, or needing to maintain hydration because they're not nursing. Oxygen therapy can be really helpful, especially if this is secondary to maybe a dystocia or a hypoxemic event. And then also some physical therapy. So maintaining them in a position where they're able to ventilate appropriately, moving their legs to try and limit the contractility. I would say the good thing is there's definitely a spectrum as far as how neurologically impaired these foals can be. Sometimes the foal just needs a little bit of support, and on the farm they're able to kind of continue. Other times we start seeing where they kind of go into multiple organ failure because they're just not perfusing appropriately, and those are definitely ones where hospitalization is not an option. Euthanasia would be kind of the next step. But no matter what you do, I would say one of the most important things is to make sure we are trying to prevent sepsis, because these guys are at an increased risk of it. So using that broad spectrum antimicrobials is going to be very, very important.
All right, so speaking of sepsis, so again, risk factors, failure of passive transfer, prematurity, dystocia, being a dummy foal. Those are all possibilities that could expose a foal to be more at risk of sepsis. You're going to see mostly lethargy and anorexia. Healthy foals are little rogues. They are little jerks, and that's what you want them to be. If you've got a foal that is lethargic, or not acting rambunctious, that's a bit of a red flag there. Typically, you want to detect as early as possible. That's going to be the biggest help. And of course, failure of passive transfer cases, you want to start intervention pretty quickly. And like Dr. Fulmer has mentioned a couple times, like early intervention is very key for these guys. And preventing it is ideal. So cleanliness, making sure you're doing like umbilical dips, things like that. Those are all going to be helpful. Using clean clothes, shoes, hands, etc. And working on foals first before you deal with any sort of sick patient, or if you have to deal with a sick patient first, making sure that you are thoroughly clean before working with a fresh baby. That would be the plan. If you do have a case that has gone towards sepsis and you're treating a sepsis case, plasma is your best friend. That is the most beneficial fluid that you can give a baby. It has a lot of good things, and it's going to be extremely beneficial for them in the 1 liter that it comes in compared to like your saline or LRS. Your antibiotic options, ampicillin and amikacin, are typically the go-tos for this treating sepsis, but any broad spectrum antibiotics are up for grabs, whatever you have available there, as long as it's broad spectrum. Some of these foals end up requiring nutritional support. So again, depending on the severity of your sepsis case, sometimes if you have a sepsis case and you can refer it. It's going to give it its best chance, but managing it on farm or in your clinic, broad spectrum antibiotics and supportive care.
Okay. So we are going to speed round through these guys because we want to make sure we have time for your questions and we get through as much as possible. So speed rounds, NI. You guys can see here, they look highlighted yellow. You're looking for evidence of jaundice. Along that lines, one of the easiest ways to diagnose it is a jaundice full agglutination test. So I saw one of the questions was asking, do you do that routinely? I don't think it's wrong. If you know you have a population where the mare has been bred repeatedly, or if you have a case where you know that the mare has been bred to the same stallion previously, I think that to be safe is a good thing to do. And again, that's something that I'll do when I'm doing that quick first exam on the foal. Before it nurses, you can collect a sample of blood, collect a sample of colostrum, and then assess that using that test. Generally, if this is identified, it is kind of has a poor prognosis, especially if they require things like a blood transfusion. However, if it's caught early, I would say overall that improves your prognosis for these guys. If it's identified within kind of that first 24 to 48 hours, I do muzzle them and separate them from the mare. But after that point, the colostrum's gone. There's really no benefit to separating them at that point, and I focus more on supportive care and that blood transfusion. And just a quick note, if anyone out there works on mules, Mules are at a higher risk for this, approximately 10%, because of that unique donkey factor that they have. And any transfusion from any other horse that has not been exposed to donkey factor should be fair for them. So it's really just any horse but their own mares should be okay. And then the next slide is just a quick summary of how that happens, but we're going to keep trucking past that so we can talk a little bit more about our musculoskeletal system.
Yeah, and I'm honestly going to breeze through this a little bit, a little more, because these are some common congenital ones. The myopathies that if you've got a mom or dad that are going to be passing that along, HYPP, PSSM, and GVED, those are all ones that you need to be on your radar. Your spinal abnormalities, dwarfism, and cleft palate, which we'll touch on a little later as well, but those are your congenital ones that you should be watching out for.
As far as the things that are considered acquired, there are some things that are kind of important to note. So physitis, that's inflammation of the physis or growth plate. It can be exacerbated by excessive growth or kind of trauma to it. So those are ones that I try to restrict the exercise, make sure that they're not putting on weight too fast. But just making sure we have kind of an appropriate calcium phosphorus balance and that we're having appropriate bone growth seems to help that. A little pain management can go a long way. I am not a surgeon. I will not pretend to be. So as far as soft tissues and fractures go, my suggestion is to work with someone who's very comfortable dealing with those types of injuries. If it's a strain or tear, that's going to be a lot of avoiding excessive exercise, giving them time to heal, and pain management. If it's a fracture, which can be caused from a variety of things, really depends on the location and what soft tissue structures are also involved in order to determine the prognosis. So when in doubt, I would take radiographs and consult. Septic joints, again, if I love septic babies, you're going to get septic joints. I do not like septic joints. They are tough to beat. They are the reason we are so aggressive with our antimicrobial therapies. If an owner calls you and says, hey, my foal is acutely lame, not weight bearing, I think it broke its leg, there's a chance. Foals do silly things. But most of the time, I will say this is the most likely cause of an acute lameness in a foal. So never roll this out until you are able to examine the foal and really put your hands on it. So clinical signs, lameness, swollen joints, heat or pain to palpation. This can be challenging, especially if you have something like a hip or something that's covered with a lot of muscle in order to really assess that. And it can be kind of subtle. To diagnose it, imaging can be very helpful. I talked about kind of radiographs or more advanced imaging can help you see is there bony involvement, has it spread to other areas. But one of the best ways to diagnose it is arthrocentesis. You're looking for a protein above 2.5 grams per deciliter or a high leukocyte count. So greater than like 30,000 cells is a general cutoff, but even greater than 10,000 cells is kind of a gray zone for me, and I definitely keep a close eye on it. And then you're also looking at the percent of neutrophils. Are they degenerative? Is it greater than 90%? All of those things can key you in. As far as treatment goes, the solution to pollution is dilution. That held true in vet school, still true here, doing lavages, especially going in if you're able to, and actually using like laparoscopic procedures and things can be very helpful. In this case, arthroscopic. I apologize, not a surgeon. And I would say when it comes to treatment, you really want to make sure that you're using antimicrobial therapies. Generally, these foals go on systemic as well as targeted therapies, whether that's in the joint or you can also do regional limb perfusions. And you want to make sure you're targeting a lot of our gram-negatives. So actinobacillus, E. coli, Klebsiella, Pseudomonas are some common ones that come from the joint, but foals also like to get gram-positive infections. So like staph can grow there, and really making sure that you have a broad spectrum approach is going to give you the best outcome.
All right, so flexural and deformities. Number one, tendon contracture. So that's where they cannot fully extend their leg. That can be from either disease or malnutrition in the mare. You can also have this happen whenever you've got abrupt feeding changes and rapid growth in an older foal. Treatment, mild cases, you can do limited exercise, bandaging, splints, and oxytetracycline on farm. Usually that's 2.5 to 3 grams of oxytetracycline. I usually dilute it in 1 liter of fluids, but that's just up to you, just slowly if you're giving it off the needle. And that can be repeated up to 3 times really for those, and you want to monitor closely. And I also recommend checking a chemistry, especially if you have to do that more than twice, but I would check it every time if you can. More chronic or severe cases, you might have to refer to a surgeon for cutting some ligaments, some check ligaments, but we hope to not have to do that. Tendon laxity, that's a very, very common thing to see. Not quite this severe usually, but it's from weak flexor tendons and you end up having that hyperextended fetlock. It's usually self-limiting with controlled exercise. The more severe cases can be addressed with some corrective trimming or shoeing. You can use light bandages to protect the limbs if they are in contact with the ground, but wrapping those limbs could lead to more laxity. So only if those are in contact with the ground, that's the only time I would use bandages on that. As far as valgus and varus, those are 2 very, very common things that we see, mild to severe. The most common is the carpal. It can also be tarsal or fetlock. And the deviation is going to vary in severity, and your radiographs can sometimes help you determine which joints are most involved and how severely. And your treatment's going to depend on severity. Mild cases are fairly normal and will spontaneously improve. If you need to get more inventive, wedging or doing extensions for the carpal valgus, you would want to do an extension on the medial aspect. For the varus, you'd want to do an extension on the lateral aspect to help correct that stance. And then there's also the windswept foal, who is just a combination of valgus and varus. And just like valgus and varus, your severity can range drastically. And in super severe cases of any of these, physial growth plate disruption is also a possibility that you can refer to someone who is comfortable doing that. I know I would not be, but that's just me.
All right, guys, jumping body systems, GI tract. This is something that very commonly happens in foals. So just to differentiate, kind of compare and contrast, foal heat should be mild and self-limiting. These foals generally don't get dehydrated. It normally happens in that kind of 5 to 15 days of birth. And the foal should be otherwise healthy. So no fever, no lethargy, no hyperemic mucous membranes. It's kind of that thought of their GI tracts just growing and adapting and having changes in the microflora. And we're seeing that change come out in some loose feces. And that is compared to foals that actually have diarrhea. And this can happen for a variety of reasons. Some infectious causes that we think of would be things like clostridial diseases, salmonella, even if they're septic, like E. coli, or there's viruses like rotavirus and coronavirus that we worry about, or protozoas. Reactions, how many of you guys got crypto in vet school? Maybe not from foals, but from calves, but foals are also susceptible to this. So that is definitely something to keep in mind. There can also be non-infectious causes of the gastroenteropathies. So that can be secondary to neonatal maladjustment syndrome. People call that kind of dummy gut, where their gut is just not capable of handling that, most likely due to hypoxic injury. Sand ingestion. I've seen some really nasty foals that had horrible sand enteropathies, and then also inappropriate nutrition. So if you're feeding a colostrum replacer or a milk replacer that's not mixed appropriately, that can also cause some diarrhea. And then another GI tract one to be concerned about is meconium impaction. I'm sure most of you guys have seen this, so I'm just going to touch on it briefly, but generally I like to start with a fleet enema. That's something owners can do at the farm. I don't do that repeatedly because of the high amount of phosphorus, and that can cause some electrolyte abnormalities. I then would progress to a soapy water enema. I tend not to do more than like a liter in my very max in my big foals. Normally it's closer to around 500 mils. And I do just some light soap in that. And sometimes I even include a little lube. And then the last one is your acetylcysteine enemas. And the foal does have to be sedated for this. I have had good success with this. And that's something that I generally try not to do an enema more than every 12 hours to prevent causing a lot of irritation to the rectum. but I will do additional therapy. So I restrict the feeding to kind of try and empty out the GI tract. Supportive care is important. You want to make sure they stay hydrated. They're not becoming hypoglycemic since they're not nursing. And then you can also do some milk of magnesia and other laxatives, and making sure that you've got some good pain management on board to help decrease inflammation and make sure that they stay comfortable is going to be important.
All right, so moving on to foal pneumonias. I know someone had a question about any tips for detecting rhodococcus, since the infection tends to be a quiet one. That's fair. Knowing the farm's history is one of those. If there has been rhodococcus on the farm or nearby, assume that someone's going to get rhodococcus, in my opinion. And as well as being really observant as far as the attitude of these foals, because respiratory signs in general are not as common in foals, as they don't present quite the same as our adult horses. What you'll see most commonly is going to be restlessness or lethargy and maybe some cyanosis, but you're not going to see nasal discharge, and a cough is not always going to present itself until you've got much more prevalent respiratory disease. Of course, thoracic radiographs and ultrasound are also really great to help detect different to detect any of those. There's a word I'm looking for, and it's not coming to me, and I don't have time to sit on it. But but determining rhodococcus versus another respiratory component is really important, so that way you actually start the appropriate therapy. Because obviously, rhodococcus, you typically use the chlorethro and rifampin, as opposed to some of our other broad spectrum things that you might use for other respiratory diseases. I also know I saw a question in there, and I'm sorry, I know I'm not getting to all of them as quickly, but I know I saw one asking about ceftiofur for sepsis. It's a broad spectrum antibiotic. If that's what you got, go for it.
Yeah, can I jump in on just those two really fast? Yeah. Great. So I have some experience with the rhodococcus foals. I really like checking fever temperatures. I find that fever can be something that, even if they're not showing a lot of other signs, you can see that kind of early on. And then also doing kind of the ultrasounds of the lungs is something, if you have a farm that you know is prevalent for that. I do think there's a risk of over-diagnosing kind of lung changes that way. So I use it in combination with look at the foal, look at the lung ultrasound, but that's something helpful. And if you do have a concern, the best way to diagnose it definitively is to do a trach wash and try to culture it. As far as the ceftiofur dose, it really kind of varies for me. Like if I'm using Naxel, I'll do like 6.6 mg per kg IM, or I go up sometimes to like 10 mg per kg. But it really depends on the patient. And I will say there's a general move to try and save our cephalosporins and not use them as kind of a first line defense as much anymore. But if that's all you have, again, I agree, that's not a bad thing to reach for.
Okay, and honestly, the rest of the slide, we all know the avenues of infection. You can get it from the placenta, environmental contamination, and aspiration. So I think we've covered that little bit.
Perfect. Someone asked about lactate. Yes. Is there much literature? No. Does it hurt them? No.
All right, and I think next is our cleft palate, which congenital defect in the roof of the mouth can involve soft palate, hard palate, or both. Typically, you're going to see difficulty swallowing and milk from the nose after nursing. You can diagnose a severe one with an oral exam. More mild ones, you may not be able to see them without endoscopy. And treatment is going to be supportive care versus surgery if it is a relatively mild case that can be corrected without too much issue, or euthanasia. Because yes, for surgery, it can only be attempted in minor cases just because of the amount of palate involved.
All right, this one we'll go through speedily. So horses can get a variety of hernias. It could be diaphragmatic, it could be umbilical. This one was actually started inguinal and then kind of spread, and that's intestine you're seeing on the side. This is going more into the surgery realm. If it's something small and is able to be reduced, it's probably okay just to monitor it. And it may resolve over 4 to 6 months. And that's specifically umbilical hernias. But again, just warn the owner that there is a risk of a strangulating lesion. And as long as they're okay with that risk, you may be able to hold off surgical intervention. However, in the case of large hernias, and especially if they develop colic signs or kind of persistent small hernias that don't repair or aren't able to be reduced, surgery is going to be the best option to fix those things. When we talk about bladder rupture, this is something that we see commonly. Foals that are down do have an increased risk of this in ones that have sepsis issues. Generally, they look pot belly, they're starting to urinate. The number one way I really like to ultrasound and then check blood work. Again, we're looking at our creatinine values, we're looking at our potassium values. If you're unsure, doing an abdominocentesis is one of the best ways. Generally, I try to stabilize these foals. If I'm pulling fluid off the abdomen, I try to replace it intravenously. I'll also try to make sure that we are correcting those electrolyte abnormalities and making sure that they are the best surgical patient possible.
Okay, so patent urachus and umbilical infection, omphalophobitis. So the urachus is your temporary structure that is used in utero to pass urine through the umbilicus. This is going to affect your pre or dismature foals and potentially lead to a septic foal. Early mild cases, you want to definitely clean and dry the umbilicus with navel dips. If you've got complicated cases, you're going to need to send them for surgery to remove that urachal stump. That's the cut and dry of it. If you're managing at home, you might want to start them on some broad spectrum antibiotics to prevent moving towards sepsis. And then of course the omphalophobitis, obviously that's an infected umbilicus or umbilical remnant. Again, it's going to affect your weak or dismature foals, or if you've got a really less than desirable sanitary environment, navel dips, the dilute chlorhexidine or iodine. And again, if you've got a mild case, treating with some antibiotics, broad spectrum, and doing those navel dips. But if you get a really gnarly infection and it needs to be surgically resected, then you'll need to send that for referral type of deal.
All right. Ooh. Ta-da.
And ultrasound is great for diagnosing that.
Last body system, I like to look at the eyeballs. One, I'm a medicine nerd, but two, they really are the window to the soul. They can give you evidence of septic infections. You can see hypopyon. You can see the hyphema that we have in there as well. You can also look for congenital issues. So sometimes if they have like lens deviation, if it's something hereditary, those are things that owners should be made aware of, as that can impact kind of their lifelong management of them. And also these guys, especially if they have entropion, can be predisposed to corneal ulcers, and they don't always do a really good job of squinting and letting us know. So don't forget about the eyeballs.
All right, flying through orphan foals. We're almost at the end. I'm sorry, guys. So if you have a colostrum bank near you, that's something to always have in your head for if you've got an orphan foal or a mare that dies during birth or has to be euthanized. Plasma, if no colostrum is available and they're greater than 12 hours old. Nurse mare is going to be great for intensity of rearing the foal, but you can, of course, do bottle or bucket feeding. I usually go for bucket because you're less likely to have a foal end up aspirating from someone feeding them incorrectly via bottle. But either way, bucket and bottle feeding is very labor intensive. So if they can get a nurse mare, that's a lot better. And then of course, foal rejection. Maiden mares are one of your main ones that are going to present with some foal rejection. This is a list of why it happens: fear, discomfort, lack of maternal instincts, and all of the tail swishing, ear pinning, kicking at the foal, pushing them away, not allowing them to nurse. All things that are basically leading the foal to not be able to get their nutrition or be able to get colostrum or milk. It's basically a lack of bonding. Main way to address it is safety first. You don't want to get hurt. You don't want the foal to get hurt. You don't want the mare to get hurt. Start with physical restraint and distraction. Food goes a long way for a lot of mares. positive reinforcement for mom letting the baby come nurse. Then we can get into the chemical and hormonal intervention. And if that doesn't work and we're up a creek without a paddle, foster or nurse mare and go back to orphan foal protocol. And there is, I think the next slide has a good summary of chemical and hormonal intervention. There's an article in the 2014 proceedings that has a really good layout. But basically you start with some sedation, trying to calm mom down and get baby drinking. If that doesn't work, then you can get in with the hormonal intervention, and oftentimes you'll need to take the foal away, give the hormonal intervention, and then bring baby back and try to facilitate that maternal bonding.
We've done it, guys. We've made it to the end. These are just some best tips that we have. I'll jump in first really quick, and then Dr. Huffman will follow up with yours. So when I was going through school, I was always taught there are two types of foals, those that are septic and those that want to be septic. So making sure you're staying on top of those really kind of nuanced clinical signs is important. Make sure we're doing everything we can to try and prevent that from happening, making sure that we're using good biosecurity, good hygiene, and as necessary, because we want to be good stewards of antimicrobial therapies, but reaching for those as necessary can really save a life.
And as I said, like near the beginning of this, foals are time sensitive. Anything mare and foal related is time sensitive. I always tell my owners, if your trailer's not hooked up and ready to go at all times whenever this mare is about to foal, you're doing it wrong. I need you to have it ready and start the truck when I arrive. And then hopefully everything will go well.
All right, we have some resources here. We have some AAP resources, and we're happy to send these out if you guys have anything. But what questions do you have that we have missed? I'm going to go ahead and open this back up. And Karen, you just tell us when to stop.
Oh, well, we could go another 5 hours probably, but I think that let's close the questions. So we do have a few questions left in the Q&A and in chat. So let's go ahead and do those, please.
Okay. I'm seeing the one, if there's a tear on the vulva, what's the timing to reconstruct or repair? I'd say that depends on which structures specifically are involved. Usually if you've got a rectovaginal tear, you're going to have to wait some time because of the amount of trauma to the area. It has to calm down before you can actually repair it. And again, Dr. Fulmar, if you have a different experience, you correct me, you do it. As far as like just vulvar tears, you can correct those pretty quickly. I typically, if we are breeding the mare back, if it's not severe enough to be a risk of infection, I will leave it until we have bred her, because with all the rectal palpations and checks, you're constantly going to be putting pressure on stitches and it will heal a little easier beforehand, especially if you're going to end up putting a Caslix in. If you're not going to put a Caslix in, repair it whenever the swelling has gone down at least enough to see what you're looking at.
No, I agree. I think that's great. There's a question about the NI foals. This is an awesome question. I think this would be a good case that you could actually send out testing. I know UC Davis does it, looking at if they have those specific antibodies that could put their foal at risk. The other thing would be if you just want to go ahead and test the foal before it comes out. I would say unless the horse that gave the transfusion is the same blood type as the stallion that did the breeding, it's unlikely to cause an issue, because that's the antibodies that they're kind of forming is to those specific antigens. But always better safe than sorry, because like you said, this one can be kind of a silent killer in foals. So better to be aggressive and on top of it. The last one was talking about dystocias. We have just enough time. We'll speed round this. I think these are tough. I think if you could feel comfortable doing an epidural, trying to keep that mare from straining. If you're able to get a lot of lube in there and kind of try to repulse the foal back and see if you can actually push the legs back into a more normal position, is going to be the best thing. If the foal's already dead, I do think a phytotomy is your best option to try and prevent trauma to the mare from ongoing or excessive traction. So again, I think if you use a ton of lube, if you attempt an epidural and try to kind of relax things and facilitate that manual manipulation and that failed, then you did the exact right thing.
And I'm seeing one in the chat about, do you often test SAA and foals alongside the IgG SNAP test? I will, especially if there is an issue that I'm concerned about. I'll also, if I'm concerned, I'm running IgG, SAA, and CVC Chem. If I'm concerned, that's all going off. If it's a routine foaling and I'm not concerned, I may or may not run the SAA. I don't know if you typically run them all for every foaling, Chelsea, or not, but
I don't, and I use this for the clinical picture. I'm old school. I'm going to give a lot of credit to Dr. Michelle Barden, if anyone knows her from UGA. The main thing you need is history and physical exam. That is going to guide you so far. And if you look at the sepsis scores that have been validated, they focus primarily on those things. So I think it's an important part of information. If you have concerns, the more information you have, the better. But it's not something that I reach for routinely.
And then I also saw Megan, she is a new grad and asked for any recommended resources that we look to for a quick reference. I think the emergency book that you mentioned earlier, that's my go-to for a lot of things. And then I have a few different proceedings papers that I've got there, like the one that I referenced for the Mare rejection. And honestly, in a pinch, Merck has some great little tidbits. If I'm just like, my brain's forgetting something, can I just remind myself about this? And it's quick and concise for me. What about you?
Yeah, there's so much out there. Finding something that's quick, I think, can be the challenge. I referenced some of Dr. Magdesian's. I really like some of his things because it's very concise. There is that one, the Equine Vet Journal had the equine resuscitation. Sorry, that word was evading me. And I find that really helpful, especially that little sheet, because if I need emergency drugs, it actually has listed by KIGS that I think the full is, like how much I need to pull up. And I don't want to be doing complicated math when I'm like actively doing chest compressions. Yeah. And those can be things that you can actually have printed out and ready at your hospital, so that if you're dealing with a dystocia or something, or even in your truck, that you can just look at it and not have to worry about calculations. So those are some good resources. We are also happy to follow up and try to post some. AAP has some really good resources available as well that we recommend, especially if you're looking more for like infectious disease and recommendations for managing that. So I think the last question I saw was asking about giving tetanus and then also PenG. Oh man, you're asking great questions. So I'll give my opinion, and then we'll put Dr. Huffman on the spot. I tend not to do PenG. I don't think it's wrong in foals. I think penicillin is a fantastic drug. My concern is just antimicrobial stewardship. There's a lot of foals that do just fine, that don't need any intervention. I don't want to expose them to something they don't need, because if they do get sick down the line, if that's not enough to knock it out, I do worry that the bugs that they are, brewing in there, all that bacteria may become resistant to it. And again, those beta lactams are one of my mainstays I reach for. So I tend not to. As far as doing the tetanus, that's also something I hold off on. Again, I kind of follow the AAP guidelines. That seems to be what most of the literature supports. But Dr. Huffman, any thoughts?
I have not done tetanus in foals. I start their vaccines fairly early in like 3 to 4 month line, but I have not given tetanus to a foal. PenG, I also haven't given. I did at my previous clinic when I was first out of vet school. We did give Exceed sub-Q to most of our babies, so that was something I had a habit of, and I broke it. But in my defense, I was a baby, and that's what they wanted me to do, so I did it.
And I bet those foals did just fine.
They did do just fine.
All right. Well,
Okay, I get to be the bad guy then and say, all right.
I guess.
All right. That was great. Attendees, what excellent questions. And we're so glad you joined us and were able to ask all those questions. The old farts. All right, I can have discussions about old farts with you if you would like. Yeah, that was great. Doctors Huffman and Fulmer, thank you so much for doing this. A great, and definitely a speed round, but hey, that's why you go back and watch the video on repeat, and you can pause and read things. Actually, I'm going to ask you to give me that page or two of references that you listed, and I can post those along with the on-demand video so that people can just click on them. So I'll chase you down for that. But thank you a million times over. Thank you so much to American Regent Animal Health, our sponsor for this session, and to Representative Kelly Matheny. We are so grateful for American Regent's support. And thanks to my backup man behind the curtain, Kevin Hinchman. Once again, we didn't have any trouble. Yay! So yeah, thank you.